Okay, our next presenter is John Hawkins, who's the Senior Vice President of Government Relationships with the Texas Hospital Association. John's been around for quite a while. He worked as a senior policy analyst for the Sunset Commission. He also served as a legislative aide in the House of Representatives for 2 sessions and a liaison for the Texas Department of Information Resources for 3 sessions. He's a native of Tyler, and without further ado, I want you to go ahead and welcome John Hawkins, or a virtual applause. John?
Thank you, Mike, and appreciate you all having me. Appreciate getting to listen to a little bit to John Henderson. We always enjoy the partnership we have with Torch, working on hospital issues. Obviously, we've been coordinating very closely on these issues related to COVID. We actually have a coordinating call every Monday morning where we're making sure we're staying close on all of these issues. So I'm going to talk a little bit about our legislative agenda, but I'll start and just talk about really what we've been working on during the pandemic on behalf of hospitals and healthcare. And really, I think John teed that up well. There's obviously a federal advocacy piece and a lot going on up there, working with our state partners, the Department of State Health Services, the governor's office, the governor's strike force, on any number of issues, whether that's the executive order related to non-essential services, or the challenges that we have had with personal protective equipment, with staffing, with the testing issues that are out there, and obviously a lot of that is ongoing. And really, what we've been working on the last few weeks is trying to deal with this surge that we're dealing with all across the state, but do it in a way where we don't just uniformly shut down hospitals for non-essential services. And we use that term non-essential. I think it's a little bit of a misnomer because we know now there is necessary medical care that was delayed when we idled all of that at the beginning of the pandemic, and folks weren't able to seek medical care that was needed, and it ended up them, when they did show up, being sicker and or having worse health outcomes. So that's a message we tried to deliver. We've tried to get the governor and the state leadership to recognize that hospitals can react nimbly to changing condition in their community. There's a lot of coordination that goes on in the community. It's not always perfect, but that's better than a one-size-fits-all. And John mentioned, the governor has amended his order initially to deal with Dallas, Bexar County, Harris, and Travis County, and then added some counties in the valley where we've seen, and along the border where we've seen a spike recently. And again, I think that's appropriate, but we're going to continue to try to advocate for hospitals to have the flexibility to deal with community needs. So just know that that's out there. I don't know if you all, any of you, have participated in. We've now, at the request of the state, are hosting twice weekly calls. I think we've moved it to 2:30 on Tuesday and Thursday, where we try to do it in 30 minutes. We've got Dr. Hellerstadt from State Health Services, along with some of the members of his team on that call. We have the governor's strike force, some of the members of the strike force, and the governor's staff. And really, we just go around the state. Again, very quickly, we know you all are providing a lot of data on a daily basis to the state, but really Dr. Hellerstadt wanted an opportunity for hospitals to report in kind of things that were happening beyond the data. So focusing on, trends, caseload trends, staffing challenges, equipment challenges, PPE challenges, folks have been reporting in on that, as well as if there are transfer issues within a region. So again, that's a lot of information to try to get done in 30 minutes, but I think we've been able to do that pretty well over the last. So if you need that call-in information, just contact us at THA, and we can make sure you've got the dial-in information for that going forward. It's also a chance for you to hear perhaps what other areas of the state are dealing with, or if there are other folks in your region that are dealing with operational issues. So again, it's kind of day to day on those issues as we work through the pandemic. But again, I think that's important from an advocacy standpoint. So John talked about the fact that, thankfully our state legislature is not meeting again until January. It's great that we weren't in a session this year. Actually, when I talked to my colleagues in other states and some of the issues they've had to deal with, actually, working remotely and trying to influence legislation. But we are trying to develop our agenda for January. Really, most of the focus right now has been at the federal level. You'll remember there's actually been, I guess, 4 fiscal relief bills that have been passed to date. And John's right, we expect there to be another. So Congress is actually, they left town yesterday. They are home for 2 weeks for the 4th of July recess, and then they'll return on July 20th. And then ostensibly they'll have 2 weeks to get their work done, because they are typically in the district during the month of August. And that's especially true in an election year like the one we're in now. So, first of all, that gives you a good chance to advocate if those members are reaching out to you during the next 2 weeks to get a better idea of some of the issues you're dealing with. But we really do need to begin our advocacy on that final fiscal relief package. And John's right, that probably is the last train that's going to leave the station for a while. There was a lot of kind of chatter about the need for that relief package. I think we had a pretty good jobs report that came out a couple weeks ago, but I think the reality of this continued surge, particularly in the Sun Belt, and obviously Texas is in the middle of that, has actually worked in our favor. I was on a call on Monday with Senator Cornyn, and he, you probably saw, was actually in Dallas on Sunday with the Vice President and with Dr. Birx, and he made the comment that, really this, what's going on in Arizona, Florida, Texas, shines the light on the need for additional fiscal relief. And I think certainly, the Texas delegation is attuned to that need. So again, I think that deal will get done. The question is, how much will it be? What will the focus be? But I think we really do need to make the point that in spite of some of the relief that's already flowed to hospitals, there's still a lot of unmet need out there. And that will continue if the economy struggles, like John mentioned, as these other sectors are impacted by what's going on with the virus. And so really our key points that we're going to make going into that next package is full forgiveness of those Medicare accelerated payments. So if you accessed those accelerated payments, obviously that was very helpful from a cash flow standpoint, but we're really trying to make the case now that for that to be true stimulus for the hospitals, we need forgiveness of those payments so they don't have to be paid back at some point given these continued fiscal challenges. So I think that's an important point to make. Obviously, we're still trying to work on the coverage side of the equation when you already lead the nation in the number of uninsured, and you have a situation economically where we know folks are losing their job or their employees are pulling back on coverage. We still need some short-term and some longer-term fixes on coverage for the uninsured. The other big point is liability protection, and I think that's something Senator Cornyn is taking the lead on. Really, other states have done this either legislatively or through executive order, but a federal fix on this would be helpful, just making sure we create a very narrow exception for hospitals and healthcare providers during the period of COVID for liability protection. And I think, unfortunately, that's going to be even more important now as we do see cases continue to increase. I saw a report last night where Arizona has already entered the level 4, which is invokes the crisis standards of care provisions that they put in place. And hopefully we won't get to that in Texas, but certainly when you do get into those tough situations, liability protection is important. To make sure healthcare providers are doing the right thing without fearing being questioned later on. And certainly we've seen the nursing homes come under scrutiny in other areas of the country based on some pretty tough situations they were put in. So liability protection, I think, is something that is going to be important going forward. So, those are really the big ones, but I think we will have the opportunity to advocate for some other items going forward. John talked about telehealth, and I would agree. A lot of this stuff that seems like we've fought tooth and nail for on telehealth, mainly on the payer side. We've been able to advance that ball pretty quickly because of the situation on the ground, and obviously it's working well. I think that's going to be the expectation going forward, and so I think we've got some real opportunities at the federal level first, and then going into the state session to make a lot of those telehealth waivers permanent and actually clarify some of the payment issues with those going forward. The other piece is the FMAP, the federal matching percentage on Medicaid. I think the third stimulus bill actually had a 6 percentage point bump in FMAP. So that means the feds actually take on 6 more points on the federal share. And that is helpful to the state budget because it means we have to put up less money to draw down those Medicaid funds. And so you've seen discussion in at least the House passed bill. The Senate will bring it up when they come back about increasing the percentage of the Medicaid program that the feds are willing to take on. And John mentioned how difficult the state session is going to be because of the pandemic and what's going on in oil and gas. And so any federal help, I think, is ultimately beneficial to providers. I mean, the challenge in that is that money accrues, obviously, to the Medicaid program, to the state, and has to be run through managed care generally. But I would argue any help on the state side is ultimately helpful when you start looking at provider rates and some of those other issues. And also remember the federal, that FMAP benefits us on the supplemental payments. So it means we have that's less we have to actually put up through IGT for DISH or for the waiver, or if you're in an area that has a provider participation fee, it just means you have to put up less provider tax to draw those federal funds down. So FMAP, I think, would be very helpful going forward, and so we'll certainly advocate for that. Eliminating the Medicaid DISH cuts, you'll remember that goes back to ACA, that the hospital cuts, both in Medicare and Medicaid, were put in place to pay for the coverage expansion. Obviously, we've been able to advocate for the fact that in a state that didn't expand Medicaid, it's not logical to go ahead and implement those Medicaid DISH cuts. Now, we've been able to kick that can down the road for several years now, given a variety of circumstances. But really, I think this is the time to make the case that permanent repeal of those would be helpful, because it's a $500 million hit to Texas and even more in the out years, and that would be problematic for safety net providers. So that certainly is on the list going forward. And then, John mentioned keeping the eye on the ball for a chance to deal with a lot of these rural hospital issues, and a lot of these CMS regulations that don't make sense, 96-hour rule, for example. I think this could potentially be a chance to deal with those. the step down idea, I think, is helpful as well, where we could decouple some of the enhanced Medicare payments from the inpatient requirement. And so we'll continue to tee those issues up as well going forward, because it does make sense to provide a little bit more flexibility going forward. So really, we'll see how much of that we can get done. But again, I think this latter part of July will be a good opportunity to make the case for all of those, given the fact that this will be probably the last train that leaves the station for a while, and then they will, particularly on the House side, enter re-election mode, and so it'll be hard to get their attention, and then we'll see what happens in a lame duck. So pretty robust federal agenda, but remember too, that's the legislative or congressional side. We also have these regulatory issues that are still out there, and John mentioned the Medicaid fiscal accountability rule, the MFAR rule. That would be catastrophic, frankly, for Texas, because of it would basically wouldn't allow us to IGT or use LPPFs for the federal share of the supplemental payments. And obviously, Texas is not the only other state. Is not the only state in that situation. It also impacts nursing homes in most other areas of the state, because they use a provider fee to support nursing home care as well. So we've got a broad base of people that are opposing that rule. John was right. We had some assurance that CMS wouldn't move forward with that, given the current fiscal situation and all the other issues that hospitals are dealing with. But notwithstanding those assurances, I think last night they did, CMS and OMB posted the rule on their agenda for action by the end of the fiscal year, through the end of September. Doesn't mean they're going to necessarily take action on that. We've got a couple calls later today to kind of compare notes on that. But it's certainly checking the box. So if they did want to move forward on it, they could. And so we've already notified some of our allies in Congress that happened, that are keeping an eye on it. So look for some advocacy on MFAR going forward. There's actually language in the bill that the House passed back in May that would preclude CMS from finalizing that rule during the pandemic. But obviously, that has not finally passed. I think there is some interest on some language like that in the Senate. But again, we would like for something much more permanent than just this pandemic. And that does bring up a good issue. One of the other things we're keeping an eye on is the national disaster declaration that the president made, and then the public health emergency that federal HHS has in place. Really doing some advocacy around keeping those declarations in place, because a lot of these waivers and the enhanced FMAP is contingent on those declarations, and so we wouldn't want those to be removed. Obviously, at some point, that's a political discussion because of some of the messaging. But again, we asked Senator Cornyn that question on Monday, and his comment was it would certainly be quote unquote tone deaf to allow those to expire, given what's going on with the pandemic right now. But you can't really bank on anything up in DC right now. So we are keeping an eye on that disaster declaration right now, which I think is important. And then kind of the final federal piece that I'll talk about before I talk about what we're seeing on the state horizon is the additional provider relief fund distributions. And so that's a couple different angles there. One is there, even after the allocations that have been made to date, there is still about $63 billion in that provider relief fund. Now, we think they're about to make an additional hotspot allocation. Again, we're going to have to wait and see what the actual hotspot definition is. So that would be helpful. That would go to hospitals. But there's still, that would leave 53 billion in there. And obviously we think there's still some unmet need, whether that are kind of Medicaid dependent facilities, because the allocations they made previously were more Medicare focused. And then, additionally, we don't think we've really addressed the whole lost revenue piece. So if you had to idle non-essential services back early on, there was certainly a lost revenue component related to that. So just revisit that. And then remember too, even though the press, often calls that the hospital relief fund, it was structured for all providers. And so we've had to do a little messaging around that a lot of those early distributions were not necessarily beneficial to the hospitals. They went to a lot of other providers, some appropriately so, others maybe not so appropriately so, but we still think there's work to be done in the hospital space. So we're trying to keep our eye on additional distributions, making sure the regulatory guidance around the money that's already been allocated is actually helpful and makes sense. But then, looking at additional distributions and really kind of going hard to the hoop for additional money in that fund in this last fiscal relief bill, because we think when you start adding up all of the economic losses going forward, it's going to be pretty significant. So we will keep advocating on money related to the fiscal relief fund. And I think, the other piece, and I can make this information available to Mike and others, is the American Hospital Association has been doing some work around actually quantifying the losses that hospitals have experienced to date and then projected through the end of the year. And again, I think that's an important message as well, because you'll hear, some members of Congress say, we've already taken care of the hospitals. Why are they still looking for fiscal relief? And when you look at the AHA just released those updated numbers yesterday, and they've got some good graphics in there about how even though it's billions of dollars of fiscal relief, it pales in comparison to the revenue losses that hospitals have and will continue to experience. And we're really working on drilling down to make sure we've got Texas-specific data on that, because remember, some of that CARES Act money actually went directly to the state and to local governments. And so I think part of our legislative strategy is going to be making sure that the state allocates some of that federal fiscal relief beyond the FMAP increase to providers as well. And so I think we're going to need to be able to tell that story about the money that's already flowed, where it went, and how much need still exists out there. So stay tuned on that information. So I will move on and talk about what we see on the state horizon. And again, John mentioned the legislature convenes in January. Not sure what that's really going to look like. Already we would have had several interim hearings on a variety of issues, and obviously none of those have been held because of the pandemic, not even virtually, frankly. And so that's kind of an interesting situation that we've been put in. We know bill filing begins in November, shortly after the election, so it'll be interesting to see what ends up in the hopper. But it could potentially be a very different session because of some of the social distancing and other public health requirements that we're going to have to deal with. So that should be interesting. But we do know, really some areas that we're going to have to focus on. And John mentioned hospital rates, and obviously anytime you're in a kind of a deficit session, we get really concerned about what might happen in the provider rate space, because remember, when you're talking about the state budget, you're really talking primarily about what we spend on public education and healthcare in the Medicaid program. Now, thankfully, most or the majority, 60% of the Medicaid program is our federal funds. In public education, that is much more of a general revenue discussion. But public education usually is the higher priority, and that creates some liability for healthcare providers. And so, John mentioned we know we still have work to do on hospital rates, particularly for rural hospitals, not just on the inpatient side, but on the outpatient side. So getting those rates fully funded is always a priority. But we will probably also have to play defense on our current rates, obviously. And so that's where, again, the FMAP percentage increase helps. And in the longer the period we can get that in place, the better, because that protects us potentially from rate cuts. But, we do have a couple add-ons for safety net hospitals. The rural outpatient piece is an add-on. So we'll certainly want to make sure we've got those in place. We'll want to keep, the eye on the ball on trauma funding, because we put a new funding mechanism in place last session, a replacement for the driver responsibility program. So we're still kind of collecting data to make sure that the revenue adds up there. So again, I think hospital rates will continue to be an issue going forward. The other piece is, we don't want to, drop the ball or cede the battlefield really on coverage expansion. You probably saw the news last night in Oklahoma. They narrowly approved a ballot initiative for Medicaid expansion. They actually had a plan in place, and the governor scuttled it, frankly, probably for political reasons, but he said he didn't trust the longevity of the financing mechanism, because the hospitals had actually stepped up and agreed to cover the state share through their provider tax, which is likely what we would need to do in Texas as well. But obviously the voters spoke, so it'll be interesting to see how they deal with that issue. But really, I would say the playing field has changed because of the pandemic, the fact that we have more uninsured, and B, the state fiscal situation. It really doesn't make sense to continue to leave those federal funds on the table that could be used to cover really the working poor in the state, adults that can't afford health insurance because of their wage, or businesses that can't, small businesses that can't afford to provide health insurance. And so we're working, already with a coalition of broad-based coalition advocates, business interests, to make that case for coverage expansion. So stay tuned on that as well. Behavioral health is again an issue we want to continue to work on, particularly with the DSRIP projects phasing out. In our 1115 waiver, we know a third of those projects are focused on behavioral health, and so that could be perhaps a more limited expansion of Medicaid, where we at least cover the seriously mentally ill that right now are being treated by those local mental health authorities. And the advantage there is those LMHAs can actually use their state appropriation as the state share. So we wouldn't be asked to put up any general revenue. The hospitals wouldn't necessarily be asked to help fund that. So there's some discussions going on related to a behavioral health coverage initiative. But again, we know, when you guys are dealing with readmissions or inappropriate use of hospital ERs, a lot of that's driven by lack of capacity in the behavioral health space. So we will continue to make that a priority. And then kind of the last issue is, we certainly worked closely with Torch last session on the property tax issues. And, who knows if that's going to be back or not, given the, current fiscal situation, that not just of the state, but of cities and counties. But we do know, a lot of what's going on politically with a response to this pandemic is frankly a continuation of that battle over state versus local control. So I'm not, we'll see if that comes back. And of course, part of that was a potential ban on public entities actually interfacing. I'm not going to call it lobbying, but just doing their civic duty of interfacing with the legislature. And obviously, we thought that was overly punitive, and we'll certainly beat back any efforts to deal with that going forward. So I think those are kind of our big issues. John's right. Telehealth will be right there with Torch on that issue. There's potentially some other, payer issues that are out there. We're continuing to work with Congressman Doggett up in DC on some of the challenges in the Medicare Advantage space. So we'll want to keep those on the agenda going forward. So that's what's known, and what always worries me is the unknown. But we won't know about that till November and beyond. But we'll be ready and work with our partners on beating the bad stuff and supporting the good stuff. So I will stop there. That's a lot of rambling, and I certainly entertain any questions.
So, John, can you elaborate a little bit on what's in the future as far as Medicare Advantage?
Yeah, so, basically what we've talked to Congressman Doggett about is just and again, a lot of you all have given us good anecdotes to deal with this, but just the fact that really the lack of federal oversight. It's just this challenge we get into where, and we deal with the managed care organizations and Medicaid as well, is that, this belief that once the state or federal government, contracts for these services, that there needs to be an arm's length from an oversight responsibility. And we know that there are some bad actors out there, and it's not always easy to bring them into compliance. And so, I would argue the state's actually done a better job because of some of the performance-based contracts that they put in place. Still not ideal, but I think the federal government is really way behind as far as the oversight of those entities. And so really what we've talked to Doggett about is just beefing up the actual oversight of those entities, both the complaint process and the sanctions if you do identify repeated violations.
And what do you see as the future of the waiver? Are we just going to have to go back every few years and try to get it extended? Or?
Yeah, that's a great question. That should have been on my notes. So we actually, our Council on Policy Development is meeting next Thursday, and really the two big things on the agenda are the coverage expansion piece and the future of the waiver. So two schools of thought out there. So really one of obviously the biggest challenge beyond MFAR, obviously that's problematic, but the biggest challenge with the waiver is the budget neutrality calculation that we're currently under. So remember, for the federal government to do a Medicaid waiver, the Office of Management and Budget has to sign off that it's budget neutral. And so, our waiver basically takes the managed care savings and moves it over to the uncompensated care pool and the DSRIP pool. So obviously DSRIP phasing out is a challenge because a lot of those DSRIP projects are actually serving non-Medicaid clients. So we can, move some of that into the current Medicaid payment, but without doing some type of an expansion, we're ultimately limited on what we can do in DSRIP. So that's one challenge. But the second is obviously, CMS and to some extent OMB, they don't want to give us credit for that savings into perpetuity. So at some point, they're going to want to rebase that budget neutrality calculation. And so when they bring that down, then that's going to limit the size of the uncompensated care pool. It would limit the size of the QUIP program and the Uniform Hospital Rate URIP program as well. And so at some point, you can make the case that you're better off scrapping the waiver because then you can build your hospital rates up to whatever is actuarially sound, which is basically what our URIP program looks like. And those can actually go up technically to Medicare rates. So we would just use our IGT or our LPPF to fund rates, but we would still need some type of, obviously, an uncompensated care pool, because they're, non-citizens, just other demographic challenges in Texas. We would still want, some type of a UC pool. So if we didn't want to negotiate the waiver, we could potentially just say, all right, let's ditch the waiver. We're going to do everything we can on rates, and then let's negotiate on a UC pool and go forward there. So that's really what we're going to probably war game, over the next 4 or 5 months, and then be able to at least take those options to the legislature, because my guess is they're going to want to put something in the Appropriations Act that, put some guardrails around that negotiation for HHSC.
Any other questions? You can just send them in through the chat option.
I think, the other part of that obviously is it's going to be interesting to see what happens in November. If we have a change in administration, that potentially, well, a couple things. One, you have to survive the lame duck period, obviously. No telling what CMS might try to do, before January, after the November results. So that's a little bit terrifying. But then obviously in January, you've got a new administration that would come in. And so then the question is, what do negotiations look like over MFAR, 1115 waivers, uncompensated care pools, and Medicaid expansion? These states that have done kind of private market alternatives for Medicaid expansion. So, obviously we'll be trying to war game all that as well, depending on the results in November.
It'll be a fun session, I'm sure.
Always. And we've got, we've got to elect a new speaker. I mean, that's the other crazy thing is, last session, notwithstanding some of, the challenges on the property tax issue, we really had a pretty straightforward session because, Dr. Zerwas was chair of appropriations. He's kind of old hand at all of this and worked well with Senator Nelson. And, he now is with UT System, I can't remember his name, Capriglione from Southlake is now chair of appropriations. And, we're there. First thing the House is going to have to do is elect a new speaker because Bonin's not running again. And so the question would be, would Capriglione continue to be the chair of appropriations, and who's chair of public health? So that, again, not ideal because you're waiting on, if there is a new administration in DC, you're waiting for all that to get set up, and then we got to break in a new speaker and potentially new chairs of some of the House committees.
Okay, any other questions? John, we appreciate your time.
Yeah, and I didn't have a fancy slide like Henderson, but just J Hawkins, JHAWKINS @THA.org. If you have any questions or other comments, let me know. Glad to help.
John, anyone can join those COVID calls on Tuesday. Is that right?
Correct. Yeah, they're very helpful.
Okay. Well, thanks again for your time. Thanks everyone for your attendance. Our next session will be next Wednesday, so watch your email for an invite from the Big Country AHEC, and look forward to seeing you then.